Hello, everyone, and welcome to the PXE International Webinar, Dermatologic Surgery and PXE with Dr. Sonia Batra. Once again, I'd like to draw your attention to the control panel on the right-hand side of your screen. There's a question pane there if you are having any technical difficulties or if you have any questions about the presentation or questions even before the presentation. You can type your questions into that pane and I will pass your questions on to the presenter. Tonight I am delighted to welcome and introduce to you Dr. Sonia Batra. Dr. Batra is in a private practice which provides medical, surgical, and cosmetic dermatology services in Santa Monica, California. She's a native of Los Angeles, but she received her bachelor's, master's of public health, and medical degrees from Harvard University. She was also a Rhodes Scholar from California and earned a master's degree in genetics at the University of Oxford, England. She completed her residency training in dermatology at Stanford, followed by an advanced fellowship training in Mohs, micrographic surgery, laser, and cosmetic dermatology in Boston. Before she went into private practice, she was the section head of dermatology and dermatologic surgery at City of Hope National Medical Center in Duarte, California. Dr. Batra's practice provides a full spectrum of medical, surgical, and cosmetic dermatology, including Mohs micrographic surgery. Today, she will speak to us about dermatologic surgery and PXE. Welcome, Dr. Batra.
Thank you so much for having me, and thank you to all of you who've logged in and are going to listen to this talk. I have drawn on my experience dealing with patients in PXE and trying to assemble some categories of common questions that arise with respect to cosmetic surgery and dermatologic surgery, but I've also allowed a lot of time for questions, so please feel free to type in your questions, and as Ms. Vokey mentioned, she'll relay them to me, so I do hope to have enough time to address people's specific concerns as well. And this audience is certainly no stranger to the disease, but just starting out talking a little bit of background about Pseudoxanthoma Elasticum, or PXE, I was interested when I started putting this talk together to realize it was actually first described by a French dermatologist, Balzer, back in 1884. We now know a great deal more about the disorder than back in the 19th century, and the genetics of PXE has been very elegantly elucidated. We now know that it's an autosomal recessive genetic disorder of the ABCC6 gene, which is an efflux prompt. It's a membrane transport protein on the 16th chromosome. The incidence based on different reports varies pretty widely, but it's a relatively rare disorder depending on any study you read. Between 1 in 25,000 people and 1 in 100,000 people are affected. And the key problem or the key issue is that the elastic fibers within the skin, as well as other substances of the body, such as the eyes and the cardiovascular system, are clumped and end up having calcium depositions on them, which markedly interferes with their elasticity. Since I'm a dermatologist and this lecture is really about dermatologic surgery and plastic surgery, I'm going to really focus more on the skin changes involved with PXE, and I'll defer to the ophthalmologist, gastroenterologist, and cardiovascular specialist to talk about some of the other manifestations. But I'm pretty familiar with the skin changes of PXE, and they fall into several categories. The presentation that comes on earliest are these flat yellowish papules in the flexural sites, meaning the sites of the body that bend, which tend to coalesce in almost a net-like or irregular pattern to create a cobblestone appearance. And the most common sites, as I'm sure all of you are familiar listening to the seminar, are on the lateral aspects of the sides of the neck, under the arms, also called the axillae, the groin, the abdomen, the thighs, the opposite side of your elbows, the inner arms, which is called the antecubital fossa, as well as the popliteal fossa, which are behind the knees. It also tends to affect later on mucosal surfaces, which are the pink moist surfaces like inside the mouth, as well as in the vaginal areas and the groin. And these are some common examples. I actually drew these from standard textbooks in dermatology because I thought the photos were much more classic and crisp presentations. But the slide I've just turned to is the classic reticulate cobblestone pattern. And the other interesting thing about this slide is you can actually see this redundancy, these folds on the side of the neck, which is another skin manifestation that I'll talk about in just a second. This is a slightly less distinct photo, but still shows this irregular cobblestone pattern on the lateral aspect of the neck. And this is a slightly more diffuse presentation. This is actually a patient's shoulder with a peau d'orange, or a reticulate yellow cobblestone pattern, which is not in a flexural area but can certainly also occur just diffusely on other areas of the body. This is a mucosal surface with the classic yellow papules on the inner portion of the gums, or the lip. And with long-standing PXE, you can certainly have calcium deposition as well. And this is where the calcium that's deposited around the elastic fibers actually tends to be much more prominent, and it creates firm bumps or plaques within the skin that are palpable. And there's a phenomenon that the calcium itself can extrude from the skin, which is called perforating PXE. And this really can cause open little sores where you actually see hard material extruding out. And this is an example from a textbook as well of calcified PXE, which presents as this dark, firm, very well-defined plaque on the lateral neck, and long-standing PXE, in this case in a pigmented person. Another skin change in PXE is because the elastic fibers are calcified, they no longer recoil or snap back the way they're meant to in the skin. And this can lead to a lot of sagging. It can lead to laxity and redundancy, which is the skin folding upon itself. The skin may hang in folds, and again, this is just because the skin is not recoiling or snapping back. It's not as elastic as it is designed to be. And this is most prominent under the arms and in the groin area, but certainly can occur anywhere. And here are just some common examples on the lateral neck, as well as under the arms. Another more recent skin change, or a more recent skin finding that's been described in PXE, was described from the dermatology literature in 2003. And this was prominent mental or chin creases. And this particular case report, which described 47 patients who had PXE, looked at the age at which people with PXE compared to the general population developed these creases. Now, the creases on the chin are a common sign, or a common change of the skin that occurs with aging, but interestingly, in people with PXE, this tends to present much earlier in life. And in this particular study, they found that people under 30, the only ones who developed these creases under the age of 30 were, in this case control study, the patients with PXE. It also showed that even under 50, more people who were under the age of 50, still relatively young, were developing much more prominent horizontal creases in this mental or in this chin area. And this also can become a cosmetic question as well, certainly earlier in life. The appearance of PXE under the microscope with a skin biopsy is pretty classic, and I think even though many of you may not be familiar with looking at skin biopsies under the microscope, it's helpful actually to look at this, because I think it's relevant when you think about surgery and you think about any sort of cosmetic procedure on the skin to know exactly where these elastic fibers that are affected in PXE lie. And this is a microscopic view of the skin. If you took a piece or a little chunk of the skin and you were to stain it and look at it under the microscope, where my arrow is right now is the outside world. This is air. This top very dark purple layer is epidermis, which is the very most superficial layer of the skin. This area here is called papillary dermis. This is the second layer of skin, but this is the higher portion of it that's closest to the epidermis. And down here where you see these clumped, irregular purple fibers, these are the elastic fibers that are clumped, distorted, and irregular, that are sort of coated with calcium in patients with PXE. So you can see actually where the changes in PXE occur tends to be fairly deep in the skin from a skin surgery or from a cosmetic perspective. And this is actually a piece of similar skin that's been stained differently. It's been stained with something called a von Casa stain, which stains calcium black. And in general, you shouldn't see in a routine skin biopsy these clumps of black. And you can see, again, that these are very deep in the skin. So this is a classic example under the microscope of PXE. Again, I think it's relevant to show this, how it looks under the microscope, and see where the actual changes that occur with PXE are, because you can see they're fairly deep. And this is relevant in terms of addressing how the skin responds to surgery and how it responds to cosmetic treatments. So this is the classic microscopic appearance of PXE. Patients who have PXE, and I have to admit they're a relatively limited number in my practice, but based on my patients as well as the literature that I reviewed in preparing for this talk, as well as just in generally in my dermatology training, I'd say that the concerns from a cosmetic or a surgical perspective tend to fall in sort of 4 categories, and I'm sure many of you may have other questions, and I'm happy to address them. But what I had prepared today was talking about removal of lax or redundant skin, which is one broad category of concerns when one thinks about cosmetic surgery in PXE. There are some patients who are definitely concerned about those mental creases that I showed because they tend to be prematurely aging. Young people do not tend to have deep creases on the chin, and those that develop them early definitely tend to seek out some way to soften them or blend them. There's often a question about how having PXE will impact other surgery, whether it's plastic surgery. I should have probably just put this as general surgery as well. The question is always, will PXE alter the way I respond or I heal? How will my skin look after surgery for other indications, whether or not it's really specifically surgery that's addressed or designed to address changes that are related to PXE, meaning, say, for example, breast augmentation. The breasts are typically not that affected in PXE, but someone who just cosmetically wants breast augmentation might be concerned about how their skin will respond to that type of surgery. And then the fourth broad category is those yellow bumps, the cobblestone appearance, how to improve and what kind of procedures might potentially address that. So what I had planned to do today is go through these categories and talk about some approaches and just what the literature says at present, meaning what the research and what clinical practice at present really says about addressing these broad categories of concerns in PXE. The first one, and I think the most common one specifically related to changes that occur as a result of PXE, is the removal of lax or redundant skin. And as I showed in the photos earlier, that's often on the lateral sides or the sides of the neck, as well as under the arms. And there are a couple approaches to addressing laxity in these areas. Commonly, say, under the arms or an area where it's more straightforward to hide a scar or hide an incision, there's direct excision, which is where the surgeon or the doctor will go in and actually numb and take out that extra skin. When one does that, the key thing is to try to hide the incision so that it's not really visible when the person is at rest or just in their normal activities. Some areas of the body it's easier to do than others, but fortunately in the flexural areas, the areas that are folded where the PXE changes tend to occur, it's often more possible to hide an actual incision line because you can hide them in a natural crease sometimes, depending on the amount of skin that has to be taken out. The other common approach is doing lift procedures where you actually go in and redrape the skin. And what this means is you would actually go under the surface of the skin and put in sutures that are intended to tighten the fascia, which is the hard, quite firm layer between skin and the underlying muscle, or actual sutures in the muscle that are intended to tighten it. And once one tightens that undersurface, that scaffolding of the skin will fall or lay differently. It's as if you were to tighten the underpinnings of any garment. You were to tighten it or cinch it in, then the fabric would lie differently, and that's what the term redraping means. When you put the skin that has now been tightened from the undersurface back over that tightened undersurface, it will lie differently, and there will be extra, and then you can actually trim the excess skin. So in both cases, whether you're actually tightening the underpinnings or you're just taking out extra skin, the goal is to, as aesthetically as possible, hide the scar. And so I had some photos of necks and kind of limited incision neck lifts. So I just wanted to show how one can address some laxity in the neck with pretty minimally invasive incisions, but the goal is always to make the result as natural as possible and to blend with the patient's surrounding skin and structures as soon as possible. In this case, you can see this healing incision. This was at suture removal 1 week after surgery, but the purpose of this slide is just to show the redraping and the tightening of the skin. This is similarly an example of what one can accomplish with surgery when you go in and you cut out the excess skin and redrape it. And these are other just small neck procedures. A common question that sort of dovetails with any kind of discussion of surgery in PXE is wound healing. And interestingly, patients with PXE, the calcification of the elastic fibers really has never been shown to affect the rate or the quality of wound healing. People shouldn't be afraid of having surgery because they think the PXE in and of itself will create a less sightly scar or a more cosmetically unsightly scar, or that the person with PXE may not heal as quickly. I've also incidentally done skin cancer removal on patients with PXE and never had an issue with those patients not healing as well or as quickly from a cancer excision as well. The one thing that you do sometimes see in PXE is because those elastic fibers deep in the skin are calcified, they may sometimes extrude through the incision point, and that can be treated with a topical antibiotic or a topical ointment just to keep the site moist and to keep it healing as one would hope to heal normally. And it's a fairly self-limited issue. It certainly isn't a reason not to have surgery or a significant complication of surgery. And I think there are sometimes questions if a patient with PXE is more predisposed to a keloid or a hypertrophic scar. And based on my review of the literature as well as my personal clinical experience, I found that there's no real elevated risk specifically due to PXE. If one has an elevated risk of keloids, or if the location on the body is a high-risk site for thick hypertrophic scarring. And there are specific locations on the body where people who do a lot of procedures are well-versed that they're more likely to keloid, specifically on the earlobes, on the upper chest, on the upper arms. Then certainly one would approach those sites with a little bit more caution for any surgery in any patient. But PXE in and of itself, based on my own experience as well as my review of the literature, is not an independent risk factor for hypertrophic or keloidal scarring. Are there any questions thus far before I shift to the next category of cosmetic concerns in PXE?
Yes, I'm not sure where they fit in, so if you want to hold till later, feel free. One person asks about treatment for perforating PXE. I know you mentioned perforating PXE already. Are you going to discuss more about treatment of it?
I don't have a specific slide on that, but in my experience, I've seen more of the perforating PXE at sites of trauma or sites of incisions, but it certainly can occur in long-standing PXE that's calcified regardless. And typically, the management of that is conservative. It's just keeping the area free of bacteria, using a topical antibiotic to prevent any secondary infection. It's sort of intuitive, perforating PXE creates an opening in the skin, and certainly that opening in the skin should be protected so it's not a portal of entry or a doorway for any sort of secondary infection with bacteria. So typically we just treat that with an ointment. We prevent a secondary infection. If it looks like there may be bacteria in the site already, we certainly would perform as appropriate a bacterial or a fungal culture to rule out any bacteria that's already entered the site from that perforation or that opening that's been created by the calcium that's extruding.
Thank you for that answer. And then there's a general question from a woman who has had several surgeries on her neck without success, she says, and I can't tell exactly what that means, but what might a person who's in that situation, what options might they have?
That's a great question. So it's a hard question to answer without knowing exactly what she means by without success. My intuitive concern about that question is it may be that the surgery, if it was a true excision, removed redundant folds, but it didn't really address the yellow cobblestoned appearance of the skin. And later on, I do address this in the presentation, but since it's been asked now, I'll preempt that a little bit by saying that the big limitation of any surgical procedure is while it's going to be able to redrape and assess or help some of the laxity and redundancy in the skin, it really doesn't address that cobblestoning or texture change of the skin. And that actually with PXE remains the long-standing critical challenge. Thus far, lasers have been approached or thought about for this, but the problem is going back to that slide that I showed you of the microscopic appearance of PXE, those calcified elastic fibers are fairly deep in the dermis. And the problem is the cobblestone appearance is a direct result of those elastic fibers, but they're deep enough that they're not really addressed by the common resurfacing lasers or even some of the non-ablative lasers, the lasers that are heat sources that are meant to stimulate fibroblasts to lay down more collagen. Those lasers are anti-aging in the average person in that they stimulate more collagen. But in cases of patients with PXE, there's no way to undo that clumping, that change in the elastic fiber, and there's no way to undo that affinity of the calcium for the clumped elastic fibers. So I wonder if that patient, if she'd like to elucidate or expand on her concerns, it would be helpful. But I wonder if the reason the neck surgery, she doesn't view it as a success is not because it didn't take out extra skin, but that the texture of her skin is still altered. And in that case, I don't have a great suggestion because there isn't really a great cosmetic or surgical intervention thus far for the cobblestoning or the color change and that texture change with PXE.
That's a very good point. Well, this particular patient would like to contact you, and I will refer her separately, privately to your office for contact.
Sure, thank you.
I have another question about rosacea. Is it common for PXE patients to also have rosacea?
I guess the short answer is they're not really related. We don't think that the dilated superficial blood vessels that we see in rosacea, and for those of the audience who aren't really familiar with rosacea is a condition where patients have in the central face predominantly, but it can be diffusely across the face, dilated superficial veins that tend to lead a red or a flushed appearance to the skin. And the secondary correlation of that is inflammatory bumps that are often described as adult acne, but they're not acne in the sense of clogged pores. They're kind of inflammatory papules that are due to mediators that are brought in by those dilated blood vessels. As far as we know, there's no disorder of the elastic fibers in rosacea. We do think that it's a condition that is inflammatory in nature and is due to the dilation of the blood vessels. My short answer to that question would be that rosacea is incredibly common. So it may be that from a genetic standpoint or just a habit standpoint, that person is predisposed to rosacea and then also happens to have the genetic disorder of PXE.
Right. Okay, thank you.
Sure.
There's no more questions at the moment.
Okay, so the next category of cosmetic concerns in PXE, as I mentioned earlier, is blending or addressing those mental creases. And those are actually among the more gratifying and easier to address aspects of the skin because fortunately we have a good template. In aging skin always develops mental creases, but the issue with PXE is that it tends to occur much earlier. So I had some photos in my files of filler for these creases. So I tried to pick some patients who did have slightly more prominent marionette lines as well as mental creases and just show that with filler, which is a relatively minimally invasive thing to do, this is where a person puts a numbing cream on and then actually has injected a gel or a sugar gel or a calcium hydroxyapatite gel under the surface of the skin. So basically those were the two modalities I was talking about. One was filler, which is just injecting a substance under the surface of the skin to fill in the creases. And the second was laser resurfacing, where we actually take a laser that's a heat source and in a very controlled way ablate or take off the top layer of the skin and thereby smooth the creases and some of the deeper mental creases, and certainly on the entire face, some signs of sun damage and aging skin. So the photos, the next slide, if you go ahead and advance to that, just show, I hope that that's advanced, it should show a before and an after of a woman with more prominent marionette lines and softening of the mental crease immediately after filler. And what I was mentioning before is if you look closely, you can see the injection points because these are immediately after injection, but those usually fade away, the needle stick points from where the filler was put in within an hour or so. And then the next slide also shows a patient with around the mouth or mental creases, and just immediately after injecting a gel, a sugar gel, which is hyaluronic acid, to fill in and soften those lines. And then the third slide, which was a before-after, was a patient who actually had carbon dioxide, a fractional carbon dioxide laser resurfacing, where we took off the top layer of the skin. And what I was mentioning earlier was the lighting on this slide is different, unfortunately, but I think you can still appreciate the softening of the creases. It's not an eraser, but it certainly makes them more shallow and cosmetically blends them a little bit better. So the next slide is surgical concerns in PXE. And as I mentioned earlier when I was giving you an overview of this topic, a question that's commonly asked is how PXE or having PXE may impact having other surgical procedures that aren't related to correcting skin changes specifically related to PXE. And one of the questions on, I think, a frequently asked list that Ms. Vokey had forwarded to me is about breast augmentation. So actually, the concern about that is that when skin that's affected by PXE is stretched, it actually causes more stress on the elastic fiber network. Those elastic fibers that are already clumped and have calcium deposition can't really recover or snap back from the stretch as well, and that may actually cause more cobblestoning and a change in the appearance of skin that previously was not on common sites of PXE, meaning that it may occur in a more diffuse way, or it may occur in that skin that's stretched even if it wasn't previously affected by common skin changes related to PXE. And some of the studies in the literature have shown that patients who've had excessive weight gain will see PXE changes in the extensor sites of the sites that aren't really in the folds. They may have it more diffusely on the shoulders or on the abdomen, or places that aren't really commonly the first places that one sees PXE. And then another common example in the literature of this is women who've had multiple pregnancies. Even though around the belly button is a site of PXE that's often described, it's more common after pregnancy. So, so the literature basically shows that procedures that are intended to stretch the skin, aesthetically the skin that's stretched may not look as good after PXE. So if one did, say, want to have a breast augmentation and have implants put in, probably discussing that with the surgeon in advance and sizing the implants appropriately so there's not as much tension or stretch on the skin from which the skin can't recover. Or even using maybe a more gradual stretch of the skin with tissue expanders may be more appropriate in a patient with PXE. This doesn't relate to just regular incisional surgery, say, for example, for appendicitis or a gallbladder, where there's no stretching of the skin involved. For incisional surgery, where one just has to make an incision and then suture the same skin back together, there's nothing in the literature that suggests there's a concern specifically related to PXE, but based on my review, I did find that procedures that are not really directed at PXE but do stretch the skin may result in PXE changes in the stretched skin.
And a related question is if a person is overweight and has a procedure to cause weight loss like gastric bypass, how would the skin of a person with PXE respond?
Well, interestingly, it may not recoil as well. So in general, after bariatric surgery, the skin that's been stretched in someone even without PXE, often there is an issue of laxity or redundancy of that skin, because when one has a bypass surgery or bariatric surgery of any type, usually it's pretty profound weight loss in the orders of hundreds of pounds. So if that patient with PXE didn't already have PXE changes in the stretched skin, in the skin where they had the heavier weight, it's unlikely that the surgery would then engender it, because if anything, you're actually taking the stretch off the skin. But the problem is that skin certainly would have even more challenges at recoiling or contracting back after the surgery. So someone who had PXE then had bariatric surgery, for that lax skin, their best option would probably be an abdominoplasty, like a tummy tuck or an actual surgical excision of that excess lax skin.
Thank you.
So moving to the next slide. This was touched upon earlier, the concern about improving the cobblestone appearance in the skin. Actually, that's the last frontier, or one of the last frontiers so far, because I have yet to come across a modality that really improves the cobblestone appearance dramatically. I do think that resurfacing is a nice idea for photo-aged skin in general. It definitely, there are common changes in sun-damaged skin that mimic those of PXE. Those are due to a condition called solar elastosis, where the sun has actually broken down elastic fibers. But specifically, if one is young and specifically doing a resurfacing type procedure to address the cobblestoning of PXE, I don't think any of the lasers really penetrate deep enough to improve that. And as I mentioned earlier, the non-ablative lasers that are meant to promote collagen, they may stimulate more collagen, which would sort of camouflage or provide a buffer layer above the calcified elastic fibers, but it won't necessarily really erase or completely remove the cobblestone appearance of the skin. So that is a challenge in PXE that remains. And unfortunately, when people do ask me this, I always say that the technology is only improving, and every year multiple new lasers come on the market that are breakthroughs, that have completely different technology or that approach the skin in a different way. So I don't think that this is a permanent issue, but hopefully some of the newer modalities or some of the research that's currently in the laser pipeline will then be applied and will be helpful for the cobblestone appearance of the skin in PXE.
I have a question related to that. Do you recommend any kind of makeup or other kind of treatment that would of not a surgical nature or chemical nature that would hide those papules, and the plaques on the neck?
Well, so the makeups can often hide the color. So a lot of times the issue of the plaques is that they're sort of a yellowish, almost like a chamois color. That can sometimes be camouflaged by more occlusive makeup that's meant for that's meant as camouflage makeup. Dermablend is in the United States a common brand that we recommend after surgery or for patients with vascular birthmarks and who really are trying to cover those lesions completely. And that's available pretty widely on the internet and through department stores. But the bigger problem is makeup doesn't really camouflage texture, and one will still see that irregularity or those raised bumps. And that, with the best makeup, even if it's a perfect color match, it's hard to really blend.
Thank you.
Sure. So moving to the next slide, I've already touched upon this with the last slide, but there are some limiting factors of cosmetic approaches and of surgery. One thing that I very briefly touched upon is obviously PXE does affect the elastic fibers in blood vessels. And so anybody who's having a larger surgical procedure and requires general anesthesia will generally require cardiac clearance. Unfortunately, the morbidity or the bigger health risks from PXE tend to lie in the blood vessels. And so prior to putting anybody under general anesthesia, which has its own inherent cardiac risks, they will need a clearance from a cardiologist who's experienced with the disorder and feels it's safe and appropriate for more of an elective or a cosmetic procedure to undergo the risk of general anesthesia. Another issue in surgery that's meant to restore or improve the cosmetic appearance or the appearance of lax or redundant skin in PXE is the question of insurance coverage. And I actually read the sample letter that was sent to me by PXE International, and I was very impressed because it is true that by law, at least in the United States, any condition that's congenital should be covered for insurance purposes if the surgical procedure is designed to correct the appearance or something that is from that congenital aspect. And as I discussed, PXE is a genetic disorder or is a known gene mutation. So the laxity and the redundant skin folds that come from PXE should be covered by most common insurance or commercial insurances, at least in the United States. The caveat is that, as we all know, often insurance companies will, as a first order of business, try to deny anything, especially something that's not commonplace. So it may require a letter or an appeal, in which case PXE International does have sample letters and resources, both for the patient who wishes to have the procedure as well as for the physician who might be performing the procedure, to try and get those procedures as necessary authorized by insurance. The other limiting factor of any surgery, and this is true whether one has PXE or not, is any cosmetic surgical procedure is not going to stop the clock. It's not going to permanently mean that the skin will never change. It will never become more lax again. It really only is a rewind type of procedure. It's meant to put the skin back to where it was however many years ago, depending on the estimation of the surgeon he or she can achieve with that particular procedure. The process of aging and the process of PXE will continue, meaning that the elastic fibers, even if they will continue to clump and they will continue to become calcified. So between ongoing sun damage and ongoing changes in the elastic fibers of the skin, even if one has a very successful procedure, one may be looking at having another procedure in 10 to 15 years. My best recommendations for that is really to use as many measures as possible to preserve the health and appearance of skin. And so as a dermatologist, I'd be remiss if I didn't at least bring up, on the next slide, you'll see some of my common recommendations for safe sun practices. Peak times for UV exposure are between 10 a.m. and 2 p.m. I always recommend sunscreens. I recommend physical blocks like hats. I recommend sunglasses, and I recommend people who are in the sun extensively to examine themselves for any major changes in the skin, like changes in moles or new lesions that could potentially be cancerous. And patients with PXE are not at elevated risk of skin cancer, but just as the rest of us, skin cancer is actually the #1 type of cancer in the world, and certainly in the United States, 1.3 million are diagnosed each year. So it's very likely that someone with PXE, just as the regular population, has a 1 in 5 chance of developing skin cancer in their lifetime. So safe sun practices will go a long way, especially if one is already concerned about changes in the skin and the appearance. Improving one's protection from the sun will help a lot to maintain the health and the appearance of the skin concomitantly along with the PXE. The next slide shows my recommendations for sunblocks. And I think specifically for patients with PXE, but any patient, physical block sunscreens are by far the most effective. They form a protective shield on the skin, meaning that they're inorganic particles that actually sit on the skin and deflect UV. Most of the chemical block sunscreens that you'll find from common products actually require UV to be absorbed in the skin and to form a chemical reaction that converts that UV into heat. There's no evidence that PXE skin is less well protected than regular skin with chemical blocks, but across the board, physical blocks are just better protection for your skin. They block both UVA and UVB. And the two common ingredients that I always recommend are titanium dioxide and zinc oxide. The newer chemical formulations are micronized, so they're not that impression that you have of a lifeguard with a white streak on the nose. Even though this picture I put up has a white streak, many of the new common preparations are not pasty. And I always recommend an SPF of at least 30. Above 30, the protection really kind of plateaus. But anything under 30, you're still in the sharper portion of the slope, and it's better to get the protection where it starts to plateau. So if you're going to bother to put a sunscreen on, I usually recommend at least a 30 and a physical block. And on the next slide, some other recommendations I have for just preserving the general health and appearance of one's skin in the lotion and potion category before you get too invasive. One mnemonic I've made up for my patients is any skin regimen should include the ABCs. The A stands for antioxidants, which include vitamin C, vitamin E, fluoretin, coenzyme Q10. These are all ingredients in skin products that are meant to mop up ongoing sun damage. The B stands for blocks, so as I mentioned, broad-spectrum sunscreens. And then the C stands for cell renewal. The most common and effective ingredients are vitamin A derivatives called retinoids, which are meant to turn over the skin, as well as growth factors, which are meant to stimulate more collagen. Now, the caveat is all of these products that are on the market really are meant to help stimulate and turn over collagen. I have yet to see a product on the market that really targets elastin, but I imagine that that will be in the pipeline. Some people have talked about bimineral complexes, such as copper, as actually being somewhat helpful for elastin fibers. Obviously, in PXE, the concern is with elastic fibers, so it would be interesting if a new product were to come on to test that and see if it had any efficacy in PXE. Thus far, in my review of the literature, I haven't seen any. But that said, keeping the rest of one's skin healthy certainly has benefits in terms of appearance as well as preventively for skin cancer. Alpha hydroxy acids are fruit acids that are meant to also turn over and sort of exfoliate the skin. And then peeling procedures like trichloroacetic acid and glycolic acid are equally safe in PXE skin as in unaffected skin. And those are also meant to help polish or take off the top layer and turn over the skin. So the next slide is sort of, the holy grail is really what are the approaches to reversing damaged or aging skin. How can you go from the picture in the top left corner to the bottom right? And there are a number of modalities. As I mentioned, limiting damage to the skin is #1. And if nothing else, if everybody leaves this lecture or this webinar with nothing else, hopefully it's the importance of using sunblock on your skin on a daily basis. As I mentioned, there are topical creams. like the retinoids and the growth factors. They're chemical peels with TCA or glycolic that are meant to turn over the skin. As I mentioned earlier, they're cosmetic injections with fillers, which are substances meant to plump and fill in the lines in the skin. Lasers can take off the top layer of the skin and or stimulate more collagen. And then surgery is scalpel-based approaches to go in and take out redundant skin to hide incisions and redrape the skin so that there's less laxity and less major signs of aging, as well as PXE in this case. So I'd like to thank everyone for their attention. This is the slide that PXE International asked me to put in, just talking about upcoming webinars. But it looks like despite our technical difficulties, we still have a few minutes in case there are any questions in the audience that I haven't addressed. I'd be happy, based on my knowledge, to try to address them.
There are a few more. One person asked about your experience of insurance coverage for the filler procedures, for example, the mental crease filler procedure.
So the short answer is, thus far, that's been challenging because mental creases, as you know, they occur in general as people age regardless. However, because that case report, or that series, that case control series, I apologize, actually appeared in the JAD in 2003, there is good evidence and an actual document out in the literature that says that this, especially in a younger patient who may be seeking filler, that it should be considered congenital and it should be covered. I will say that it will be challenging, and one will probably have to write a number of letters to get it through. I've only had one patient in whom I've gotten it approved.
And again, PXE International can customize our support letter for plastic surgery. So if you would like to try to appeal or present your case before you opt to have surgery, we can give you a personalized letter of support. You need to contact me, cvoki@pxe.org, for that. Another person asks if you could reiterate a couple things about pregnancy. How would the skin of someone with PXE respond to a C-section, and what is the impact of pregnancy on the skin of a person with PXE?
Okay, so the first aspect in terms of wound healing from a C-section, I don't believe there's any specific concern with respect to the PXE. A C-section is an incisional wound, so meaning it's a wound that's created by a scalpel, and so the wound healing should be comparable between a patient with PXE and a patient who didn't have PXE for the actual surgical site. It should heal equally quickly. Obviously, one would need to take the same precautions against infection. The only concern about the incision would be there might be possible extrusion of calcium through the incisional wound, which, as I mentioned earlier, would be treated conservatively. One would put a topical antibiotic on it. One would try to really keep it sealed to make sure that it didn't become secondarily infected. Unfortunately, any incisional wound can become infected, so the surgeon would have to be meticulous in sterile technique and also in prescribing a preventive antibiotic as appropriate based on the patient's history. With respect to stretching of the skin in PXE, I think, as I mentioned, there have been case reports or studies in the literature that have shown that the degree of stretch definitely can create PXE changes in skin because of that calcification of the elastic. But it's my best analogy would be even when patients ask me about stretch marks in the skin, which are also injuries to the elastic fibers from very rapid changes or tension on the skin. And one way to minimize either of those issues or either of those changes is to really gain the weight in pregnancy very gradually and really try with one's obstetrician to stagger and plan for the weight gain so that it's consistent throughout the pregnancy. Most people who are at normal weight should be gaining about 25 to 35 pounds in a pregnancy. So kind of targeting just an optimal weight gain, trying not to go too far over the weight gain that your obstetrician feels is safe and appropriate based on your start weight, and really kind of staggering that over 9 to 10 months so that there's not a rapid, sudden stress on those elastic fibers, is more likely to preserve them so that they don't have the issue of aberrant clumping, of injury, and then the calcification that ensues with PXE.
Okay. And then someone asked if you use laser, is laser an option for the neck, or do you just use it on the face?
Fractional lasers can be used on the neck. Again, we would predominantly use them on the neck for aging skin. I have yet to see a laser that really, if the laser is being targeted more for the cobblestoning of PXE, that really provides a dramatic result. But yes, it is safe to use a fractional CO2 laser if the practitioner is experienced and understands the setting on the neck.
Okay. And here's another question. Do you have any experience with lip surgery to decrease the elasticity in the lip?
Unfortunately, I don't have any personal experience with that. I would have to defer to probably an otolaryngologist or someone who specifically focuses their procedures on the lips.
Mm-hmm. Okay. I think that is all the questions we have. We have a couple people who would probably like to contact you, and I will send those people your office information privately. I would like to thank you very much for presenting this overview of dermatological surgery and PXE. Dr. Batra, thank you for your time and for being with us tonight.
Well, thank you for having me, and thank you all for making the time to attend this presentation. Thanks for your attention.
And Dr. Batra will also be speaking in person at our member meeting, our biennial member meeting, which is September 10th to 12th in the Washington, D.C. area this year. And if you can come at all, please do. We'd love to have you join us. And like Dr. Batra said, there are 2 webinars currently scheduled, 2 more. They are called Building a Career Without Boundaries, presented by Kate Williams, who is a person with PXE and vision loss, and helps people re-educate themselves for a career after vision loss. So I think you will enjoy seeing those, participating in those. You can register from our website. And again, if anyone is interested in a letter of support for reconstructive or any kind of surgical dermatologic surgery, you can email me at any address, and there's an address on the screen, info, I-N-F-O, @pxe.org. I will get those emails. Or my personal email, cvocke @pxe.org. Again, I'm Christine Vokey, Director of Education and Information at PXE International, and thank you all for joining us, and thank you again, Dr. Batra.
Oh, you're very welcome. Thanks again.